Hi everybody, I'm Marie and I am an ICU nurse, and I understand that we're going to be having some people come into our unit that don't really have a critical care background, or maybe they've been in the critical care setting and then went away from it and now they're coming back. The first thing I want to say is you can do this. It's not rocket science. It's just skills that are learned and get better with practice. And you will have a lot of mentors around you to encourage you and to guide you and to answer questions. I wanted to give a few things, say a few things that I tell everybody that I might train, and pass on the things that were given to me when I first became an ICU nurse, and it still sticks into my head today. And I'm just going to give a couple quick overview points on each body system and also ICU nursing as a whole, and what I think will make you very successful. The main point of ICU nursing is, treating and preventing critical issues. We get patients who maybe have something that could have been prevented if that nurse was able to recognize it and provide an intervention. And sometimes when they get to ICU, then it's a critical problem where maybe it could have been prevented in the beginning. Our job for a patient who's stable is to figure out what is the worst thing that could happen to that patient, and figure out what you're going to do about it if it should happen. I can't stress that enough. When you get an assignment, what's the diagnosis, what's going on, and what is the worst possible thing that could happen, and be ready for it to happen. If you're ready, it probably won't happen. I think the other thing that I like to stress to people is to watch trends. The trend is what is our clue of that maybe something is happening that maybe we could fix before it becomes a really bad issue. So, and it applies to neuro, to respiratory, to cardiovascular, to urine, to GI. Every single one of those body systems has a baseline, but then that patient has a trend. Is it going this way or is it going that way? And that's where your thinking cap comes in, and that's where you can go to your colleagues and say, hey, this is happening, and what do you think? And then we can discuss, okay, yes, it's time, let's get the doctor involved, and maybe he can place an order to address this issue. Neuro. I doubt you'll be getting critical neuro patients. The Neuro Intervention is brand new to us at Jupiter Medical Center, and none of us are really super experienced in it. We're doing our best, so I don't think that those will be coming along your path. One thing I can say for neuro is what's the baseline? Are there any changes, especially level of consciousness? Know how that patient was when you got them. Talk to the nurse you got report from. Were they talking? Do they know where they are? ICU delirium is a real thing. Patients become a little psychotic from not knowing what time it is, being woken up around the clock. The medications we're giving them can make a normal person act in a very psychotic way. And we have treatments for that, and that's something that maybe you can, if you see something that's not right, reach out to one of your colleagues or your peers or your charge nurse and find out what we can do about it. One thing to pay attention to is, if it's a patient who's not sedated, are they moving all their extremities? Can they move both arms? Can they move both legs? Can they answer questions appropriately? That's key, and that's your baseline. If it changes, there could be a problem. Sometimes for delirious patients, the best, intervention could be putting mittens on them to keep them safe and keep them from crawling out of bed. Make sure your bed alarm's on, and that's something I can't stress enough, when your shift starts, check your bed alarm. So mittens are great, and if we need to use restraints, we will, or a roll belt. We try not to because it's just more charting. Anyway. Respiratory, don't get hung up on different breath sounds. We have so many different breath sounds that are adventitious, but what you need to know is what's normal. Do you know what clear breath sounds sound like? Listen to your own breath sounds, and that's what clear breath sounds hopefully sound like. So if it doesn't sound like that, it's not normal, and you can get a second opinion. But you want to really listen on the backside from the top all the way to the bottom. And are they oxygenating, or are they getting a full respiration all the way down to the bottom? Did they have a chest x-ray, and what was the result yesterday? And let's take a look at it, and we can look at it together. We can read the radiology report, or we can pull up the film, and we can have a little overview and a quick x-ray reading lesson if you're with me. One thing to, again, we're going to go back to trends. What's this patient's baseline? Are they improving? Are they getting worse? How much oxygen is being delivered to this patient? And what's their oxygen saturation? Are they a CO2 retainer? Do they have COPD? Do they use oxygen at home? Maybe 89% is a normal sat for them. Make sure the oxygen's plugged in. This was something that's happened to me. I went in to visit one of my best friends in the hospital, and he was in rapid atrial fib, and I looked down and his oxygen wasn't plugged in. Make sure it's plugged in. If the patient is on a ventilator, what's the oxygen setting, and what are they satting? Are they tachypnic? Are they breathing above what you would think they would breathe, or what's normal, respiratory rate of 18, or maybe a respiratory rate of 24, but if all of a sudden it turns into 36, okay, why? Always ask why, and then maybe it's time to consider getting an arterial blood gas, because maybe that patient's becoming acidotic, or maybe they're going into renal failure, and you're going to see that probably on a gas that's going to affect, all the systems, kind of talk to each other. If you do have a ventilator, make sure that, pay attention to where your endotracheal tube is right at the lip. Typically we'll write it up on the whiteboard, or respiratory will document it in their charting. But you want to know if it moves. If it moves, that's a problem. It could kill the patient. Make sure that ET tube holder is secure. And, what else can I say about ventilators? If it's alarming, come get one of us. Sometimes there are just some settings that need to be changed by respiratory, or something has become disconnected. What else can I say? Sedation. Ventilated patients are sedated. Typically, back in my day, we always use propofol, but I'm finding some of our intensivists like to use fentanyl mixed with Versed, and use the two of them together. Or sometimes some patients can handle just Precedex, which is okay. But anyway, if you want to get familiar with sedatives, I would get familiar with propofol. I would get familiar with fentanyl, and probably Versed and Precedex. And I think in our ICU guide possibly, or there's a place where we can find some drip sheets. I know we have a drip sheet, but it'd be nice to have like a little, you can print online. There's all kinds of drip calculators to help you. Cardiovascular. So again, going back to what is their baseline? What is their base rhythm? Is it normal sinus rhythm, or are they normally in AFib? If they're normally in AFib, are they anticoagulated? If their baseline is a heart rate of 40, okay, that's great, but what if it changes to 140, or what if it changes to 20? Or what if they lose their P wave? These are all things that you want to watch. What's the normal? What is it when you got the patient? What was it on day shift or night shift? And what is it now? And it's just detecting little changes that will not only make you successful, but also have a positive outcome for the patient. What else? Let's see. Okay, so a lot of times what you'll see in ICU is you'll see, you will see an SVT, you'll see a rapid AFib, or you'll see somebody tachycardic. Happens a lot, but why? Always ask yourself why. Why is this happening? Why is that patient's heart rate 120? Is the answer to give a beta blocker? No, not always. Find out why. Does the patient have a fever? And when it comes to measuring a temperature, let me just go off on a little side note. The right place to measure oral temperature is back in the buccal sac, all the way back here. It hurts a little bit. I mean, don't jam it back there, but it's not comfortable for the patient. You're an ICU nurse now, so take a rectal temp. That is the most accurate way. If you suspect a fever, get a rectal temp. Can we treat that patient with Tylenol? If their liver's fine, then yes, that's the ideal thing to do. But also consider, are they being treated for an infection? Do we need to notify the infectious disease doctor? Is it somebody who doesn't want to know if they're, going to be spiking a fever? Have they been pan cultured? Maybe go ahead and read the progress notes from the infectious disease doctor if there is one on the case, or just notify your intensivist, and they will guide you from there. Other reasons to be tachycardic would be dehydration. Sometimes we will maybe diurese a patient with Lasix or something else, or we'll be withholding fluids, but then, now we have nothing to pump in our intravascular space. So, consider maybe they need a little bit more fluid, or that we need to change the fluid rate. If they're not eating well and they're not on IV fluids, that's something that we have to address. Tachycardia, they could have paroxysmal atrial fibrillation. Maybe they are wanting to go into AFib, or maybe their heart's under a little stress. There's all different kinds of reasons for having tachycardia, but like anything else in any other system in ICU, why? What's the trend and why? GI. Well, let me go. Oh, one more thing on cardiovascular. The most common drip you'll see for hypotension is Levophed. That's primarily what we use in our hospital. It used to be used in mics per minute, but now we're doing mics per kilo per minute, which I still am having a hard time wrapping my head around after doing mics per minute for so many years. But that's a drip that you should become familiar with. And we always want, everybody always said, oh, you want to mean a 60, but, I find the gold standard is usually around 65. If you talk to some of the renal doctors, they're going to say 65, and you want to make sure that, that blood pressure and that urine output are probably going to go hand in hand. And those are two things that you need to consider together. And then also with titrating drips for blood pressure, if you have, one other thing, blood pressure cuffs. So blood pressure cuffs, it's not about how big the patient is, it's about the length of patient arm. So you want that blood pressure cuff to be 2/3 of the length of this part of the arm. If they're a teeny tiny little lady, but they have a long arm, they don't get the teeny tiny little blood pressure cuff. A normal blood pressure cuff is fine. If it's a big lady, but they have a normal arm, then use the long medium cuff. And then you might have to get creative, because we do have people with all different body shapes and sizes. That's going to affect, the outcome of the patient having proper measurements. And then also pay attention to how often are you squeezing that person's arm. Sometimes they'll come back from surgery and we're squeezing it every 5 minutes, or maybe it's an admission, we're squeezing it every 15 minutes, but then, no one ever changed it, and that poor person has been getting their arm squeezed every 15 minutes for the entire shift. And it's disturbing, and they're not able to get a good night's sleep when that's happening. So pay attention to that and just squeeze it as much as you need to squeeze it. That's my terminology, sorry. So blood pressure, if you are titrating a drip, probably every 15 minutes, maybe every 5 or 10 minutes, until you get that patient stable. But if you have a blood pressure and you're seeing a trend of you've got a map of 70 and a map of 70 and maybe systolic of in the 120s, start coming down on that drip. It's helpful to them in a critical time, but long term it's not a helpful thing, so we want those drips off as soon as possible if we're able to. GI. A lot of us tend to forget about the GI system, but yes, we want to know, okay, when did they last poop? If it's been days, we need to address that. Do they have bowel sounds? Is their abdomen firm and distended? Is it tympanic? Tympanic meaning if you kind of tap on it a little bit, you're going to hear a hollow, like drum beat sound. Is it possible that maybe they need an NG tube and to decompress the abdomen? Are they maybe they have, a blockage or an ileus, or and there's meds that we can do to help things along if needed. Pay attention to it. It is an important part of the system. And do they have diarrhea? Does it smell really bad? Consider sending a C. diff sample. If it's liquidy, watery, we have a tube for that, but please get an order before inserting one, or talk to your charge nurse. If they're bleeding rectally, or even, the emesis, bloody emesis, make sure we're monitoring serial H&Hs. Make sure somebody knows about it. If it's new onset, GI bleed, we need to make sure a clinician's informed, and generally a GI doc will be put on the case. So renal is, I got to tell you, a lot of our patients are sick. They end up needing dialysis. Sometimes they come in with renal disease, and sometimes we cause renal disease because, maybe the patient went through sepsis and didn't get the right perfusion they needed. And, so it's something that we can help with, and we're helping by monitoring trends, measuring our output. We have urometers for a reason, and we really need to look at that urine output every single hour. So, if you're under the old rule of thumb, and really it should still apply, but I never hear it talked about, is, if you have less than 30 cc's an hour for 2 hours, then you need to call the doctor. Maybe they need a fluid bolus, maybe they need Lasix, but let that doctor decide what to do. Sometimes, if you don't see any urine output, there could be a problem with the catheter. Maybe the catheter's kinked. Maybe it needs to be flushed because they have a lot of sediment and it needs to, maybe we need to flush it. Maybe we need to do a bladder scan and see if there's any urine in there at all. And that's a really important system to watch your trend. So what's their normal, and what's the worst problem that can happen? Worst problem for renal definitely is no urine output for several hours, and they're going to go into renal failure pretty quick. Lines, we have central lines, we have PICC lines, we have mid lines, we have power glides. You know what? They're pretty much, I'm not going to say they're all the same, they're not, but as far as you're concerned, just make sure you flush them, scrub the hub. The new standard of care is, to use chlorhexidine and not alcohol. Scrub the hub, flush that line, make sure your lines are patent and healthy, so we can use them and don't lose access. It's really important to have access in the ICU. What can I say about lines? Oh, drips, drip compatibility. Where I go to check for drip compatibility is on Micromedics. From the GMC homepage, I go to Micromedics and check for IV compatibility, and I put together as many things as I can when I don't have a lot of lines. If you have a patient and you want to decide if it's a line draw or a stick, if you have a patient who's on 1, 2, 3, or 4 drips and that's the only line you have, I would think if you can stick that patient for labs, I would do that, because if you withdraw 10 cc's out of that line that's full of drips, and then you take your labs out and then you hook your drips back up, well, guess what? It's going to take you probably 5 minutes before that patient's going to get that therapeutic amount of drips. So you don't want to take the drip away from them. So definitely, if you don't have lines and all you have are running through there are drips that are life-sustaining, don't use that for a lab draw. Have labs stick them. Chest x-rays. Some patients need daily chest x-rays, especially ones with chest tubes. Some patients don't need daily chest x-rays. So I would suggest just checking your orders, and I like to look at, I like to read my chest x-rays, not read them. I'm not a radiologist, but I have been trained by some really great nurses to actually look at chest x-rays. But read the report, read what the radiologist has to say, and then here again, this is an important thing. What's the trend? So what was yesterday's chest x-ray and the one before that, and watch the trend throughout those couple days. Labs, typically we should have daily labs in on most of our ICU patients. If we don't have labs in, check and see. Sometimes it's overlooked. Ask your charge nurse or ask the intensivist when you have their attention to see if they want daily labs. Typically we're going to see either a basic or a comprehensive metabolic panel, or you're going to see a CBC, possibly coags. And I think that's pretty much it for daily labs for us. Chest tubes. The most important thing for chest tubes is make sure they're not kinked. Make sure it's dressed well. Make sure your dressing's clean, dry, and intact. I think some people I think Dr. Lee prefers Vaseline gauze around the insertion site, which is a good practice. Make sure it's connected to suction. Make sure the suction is turned on. And then just check and look in the actual chest tube container. There's a little orange indicator that shows if it's getting the right amount of suction. Again, here there's trends. You look at your output. If the output is just kind of stays the same as what's expected for that patient, then that's fine. But if all of a sudden you have a big output, then that's something that the surgeon or the intensivist needs to be notified of. Also, do you have an air leak? And what's the baseline air leak? Is it getting worse? Is it getting better? And then around the chest tube insertion site, you want to look for Crepitus. Crepitus feels like little, like those, it just feels like Rice Krispies. I can't explain it, but I can feel it. And, we're all here as backups to help you through this. Suction setup in the rooms, just be careful. Some of our suction regulators can be a little temperamental, and so there's like little tricks to get them to work, but make sure, that if you don't have a ventilated patient and you just have a patient that's on normal O2, always make sure that there is suction ready to go for that patient with a yank hour. Because that patient could be need intubation at any moment, and you want that suction there ready to assist the intensivist who's doing the intubation. Room cleanliness. So I can't stress this. This is my biggest, probably one of my biggest pet peeves is coming into a dirty room. Some people are neater than others. Please, take in the supplies that you need, and just take a second to put all your linens in one spot. Take a second to just organize stuff so the next nurse coming behind you can see what's available. Sometimes I'll open a drawer and there's just a bunch of stuff thrown in there, and it's not really helping the productivity of anyone. I can remember being trained by Annie at Palm Beach Gardens, and I'll just never forget, you can't leave the alcohol wipe on the floor. It was like, those ladies made me nervous. Safety, the most important thing is your safety, number one. Watch your back. Use the bed inflation if you're lifting up a patient. Get help. Do not try to lift a patient by yourself, boosting a patient up in bed. You want to make sure, especially if you have somebody maybe going through alcohol withdrawal who's possibly violent, you want to make sure that you're not in a position to get kicked or hit. Your safety is number one. Watch out for cords on the ground, and, try not to leave any laying out. And, then the patient safety would come next for sure. So, make sure the bed alarms are on. Make sure they're not going to maybe jump over the side rails and, run for the bathroom or something, and educating the patients too as to what to expect, I think will help have a successful shift as well. And then preventing skin breakdown, that's just common sense. If they can't move themselves, then you need to move them and turn them. Make sure, they don't have a body part leaning up against the side rail or their toes up against the footboard. Anyway, that was just a quick little overview of just very simple things. And, again, I'll just go back to what is their normal and what's the trend, and preventing problems. And that's what you're here helping us for. And I just want you to know that I believe in you and I know you can do it. And we're all here to support you. We have a really good team at Jupiter's ICU. Thank you.